let's talk about appendix or appendicitis. It is an acute inflammation of the appendix, can be due to obstruction by fecalith in adults or lymphoid hyperplasia in children. Proximal obstruction of appendiceal lumen leads to closed loop obstruction, which leads to increased intraluminal pressure, which causes stimulation of the visceral afferent nerve fibers at the T8, T10. This leads to initial diffuse periumbilical pain, which leads to inflammation. If the inflammation was to extend to the serosa, that's going to irritate the parietal peritoneum, and that pain is going to be localized towards the right lower quadrant, or the McBury point, which is 1/3 from the distal, 1/3 distance from the right anterior superior iliac spine to the umbilicus. Nausea, fever, may perforate, which leads to peritonitis, may elicit psoas sign, obturator sign, a Rovsing sign, which is a severe right lower quadrant pain with palpation of the left lower quadrant. Guarding is there, rebound tenderness is there. Treatment is appendectomy. Now the important points here are that at first, when you have this appendicitis, at first you have the periumbilical pain, and then that periumbilical pain is going to go down towards the right lower quadrant. And the question is why? Because when you close that loop, when you obstruct that, looking at this picture, when you obstruct the appendix, it causes stimulation. It first of all increases the intraluminal pressure because of obstruction, which leads to stimulation of the visceral afferent nerve fibers at the T8. Okay, it sends the pain to the through the visceral afferent nerve fibers at the T8, which causes a diffuse sort of pain, which is the periumbilical pain. But when the inflammation hits the serosa, remember the MS, mucosa, submucosa, muscularis externa, and serosa. So when you have, so let me just do it this way. So you have here, MS. So when that inflammation, it was just here, it was blocking the tube, you increases the intraluminal pressure, you stimulated your visceral nerves, which gave you a diffuse pain at the periumbilicus. But as soon as that inflammation touched the serosa of the appendix, now you irritated the parietal peritoneum, and that parietal peritoneum is specific location, which is your right lower quadrant. So you have that right lower quadrant pain, and that is that right lower quadrant pain. The point, it's called the McBury's point, which is anatomically 1/3 distance from the right anterior superior iliac spine to the umbilicus, or 2/3 difference from the umbilicus to the anterior superior iliac spine. So if this is anterior superior iliac spine, and this is your umbilicus, it is 1/3. So it's just here, or it is 1/3 from AFIS, or it is 2/3 from the umbilicus. So 1/3, 2/3. So although they have mentioned 1/3 here, but just keep that in mind, that you will see 2/3. They will just say 2/3 from the umbilicus, the pain elicits. So that is again same thing, McBury's point. Okay, it gives you also the nausea, the vomiting, the fever. Not the vomiting, but the nausea and the fever. But it could perforate and cause peritonitis. Now the signs are really important. You have the You have the psoas sign, you have the obturator sign. The psoas sign, the obturator sign. Okay, so what is the psoas sign? The psoas sign, it is the pain on hip extension. Pain on hip extension. Okay, and hip extension. Remember, flexion is when two body parts are coming close together. Extension is when the two body parts are moving further apart. So when you were to do a hip extension, and you have a pain, that is psoas sign positive. And the obturator is, you have the pain by internal rotation. Pain on internal rotation. Internal rotation of the hip joint. This leads to obturator internus muscle gets in contact with the inflamed appendix. So obturator sign is pain on internal rotation of the hip joint. And the mechanism is that obturator internus gets in contact with inflamed appendix, and it causes pain. Rovsing sign, which is severe right lower quadrant pain. You have a severe right lower quadrant pain here if you were to palpate the left lower quadrant. So you're palpating this area, but you're having pain, severe pain here. That is the Rovsing sign. The guarding is there. That the person will like, oh, so that's the guarding. Like you're contracting the muscles as soon as you touch it, as soon as you palpate it. That's the guarding. And you have the rebound tenderness. Again, rebound tenderness on the physical examination. Differentials or differential diagnosis to all of this. You could have diverticulitis. You could have ectopic pregnancy. So you have to use an ACG to rule out an ectopic pregnancy first. Okay, or you could have pseudo appendicitis. Okay, treatment is always appendectomy. Now, one other clinical tie-in could be if somebody has a patient who has a retrocecal appendix. Retrocecal appendix may not have significant right lower quadrant pain or tenderness, as the inflamed appendix doesn't get the contact with the anterior parietal peritoneum, and the cecum acts as the cushioning that blocks the hand. So again, if you have a retrocecum, so if cecum is here, so instead of that appendix here, it is behind this. So if you were to do all of these examinations, you're not going to have a lot of pain, even in your palpation, because that hand, that on examination, you're not even pushing the appendix, so you're not going to have pain. So that's the retrocecal appendix. What is the etiology of all of it? The etiology is either you're having an obstruction by the fecal lith in adults or lymphoid hyperplasia in children. Okay, that's all what we have for the appendix.